Hi, this is Brian Kim. I want to share with you this case of the patient that I did in the previous video last week. The patient had an anterior capsule tear because I must have chopped the capsule doing the cross-chop maneuver, but fortunately I was able to get the lens pieces out, the endonucleus, the epinucleus, the cortex, and I positioned a single piece acrylic lens perpendicular to the tear in the bag. Everything went great. Dealing with these situations, putting the lens in the bag perpendicular to the tear, an anterior capsule tear, this typically does not propagate. The lens stays put and the patient ends up doing great. However, this patient had a vomiting fit post-op day 0 that night and then saw my partner post-op day 1. The lens was decentered and there was a large bolus of vitreous in the anterior chamber. And so what I think happened was the patient vomited. It caused increased intraocular pressure, intrathoracic pressure, and she must have burped the wound. And when it burped the wound, the chamber collapsed and the posterior capsule split, vitreous came forward, and the lens decentered. And so, again, I've never run into trouble, but the learning point is, in this situation, in retrospect, I could have sutured the wound. So you can see here the lens is severely dislocated. Again, at the end of the case, the lens looked great, but now it's severely dislocated and there's a wad of vitreous in the anterior chamber. So I use a wet cell sponge to dry the surface of the eye, and I make a limbal mark using the 27 gauge cannula. The tip of that cannula is inked, and then using that same cannula, I'm identifying 180 degrees apart on the other side and marking the limbus on the left side. This is a fixed caliper from Epsilon. I don't have any financial interest in that. I indent 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent, and then ink those indentations. I do the same thing on the left side, indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent, making sure you dry the surface very well. It has to be dry to get those discrete marks, and then you ink those indentations. Using the back of the trocar, I indent the sclera 3.5 millimeters posterior to the limbus, and then tunneling with the needle 3 millimeters towards that indentation, and then diving down. You can see the cannula sitting a little bit sideways, which hopefully means it'll be a self-sealing incision. I make my incision on the right side and the left side. These are my incisions to help me take the lens out. This is the incision to externalize the leading haptic through a 25 gauge needle passive docking technique. And this is the incision for my AC maintainer. This is intracameral triamcinolone. This is my 22 gauge thin-walled AC maintainer. And this is anterior vitrectomy, removing that vitreous in the anterior chamber, filling the eye with dispersive viscoelastic, and then removing the lens. Using 2 forceps, I grab the optic, carefully lift it, pop that first haptic up. The left side, you just bend it so that it goes into the anterior chamber. Bend the right haptic in a similar fashion. Hold it with the serrated forceps, and then cutting the lens with the micro scissors. Cutting it 90%, and then I'm going to Pac-Man the lens out. Grabbing the right side piece, pulling the right side piece out first, and then rotating it so that the other side can come out. Rotating the lens so that that second piece can come out. And the haptic is able to collapse on itself doing so. Doing some more anterior vitrectomy. Sweeping the incision There is some vitreous there. Making sure I eat up that vitreous. You want to stay high with the vitrector so you're eating the pieces that are external. This minimizes distraction on the retina. Injecting some more triamcinolone. And as I do this, you can see there's a little bit of vitreous within the incision right there. You can see it. Eat that piece up. The wound is free of vitreous now. Closing that incision with a 10-0 nylon suture. Again, that is my phaco incision, right? And so I didn't open up that incision, but because this patient had the trauma, the vitreous was through that incision, you can see. So I go ahead and switch to the supratemporal location and pushing dispersive viscoelastic in. This is my 3mm blade that I'm making, again, supratemporally. And again, that's perpendicular to my limbal marks. This is a 25 gauge needle. I'm going to bend it so that the bevel is facing to the right. And this is to externalize the leading haptic through the contralateral limbal incision. This is my 30 gauge thin wall needle for the right side. I bend it about 9mm from the tip, and the bevel is going to face towards me. This is the left side needle. I bend it at the hub with the bevel facing away from me. Injecting cohesive viscoelastic in the emerald cartridge in the barrel and on the platform. This is the Sensor AR40 lens. Push it down, the optic into the platform, making sure it's seated down. Bring the wings together. The optic should bend backwards. The leading haptic should go straight through the barrel and the trailing haptic out through the back. Place the cartridge into the injector, making sure the trailing haptic is up and away from the barrel as I push the plunger forward. Placing the 25 gauge needle through my contralateral limbal incision, making sure both the needle bevel and the injector bevel are facing each other. My assistant is delivering the lens. I dock the haptic on the bevel of the needle. The bevel of the needle allows the haptic to glide into the needle. As I pull the needle out, the haptic comes out. I take over, making sure the optic comes out correctly and the trailing haptic comes out facing to the right. Pushing some dispersive viscoelastic to push the optic back and coat the cornea some more. You want to move the lens away. Holding the trocar cannula with the forceps, I puncture the conjunctiva and sclera at the first mark, turn on infusion, tunnel 2mm, making sure I feel the resistance of the needle going through the sclera so it's within the scleral tissue for the whole 2mm, and then diving down. Doing a sideways slide maneuver using my smooth micro forceps from MST. I'm able to slide the haptic in, the trailing haptic, docking the haptic on the bevel of the needle. 2 pushes and I'm in. Disengaging the needle from the syringe. Pulling the leading haptic into the angle. Holding the eye using the forceps, the Colibri forceps through a contralateral limbal incision, holding it with counterfixation, stabbing the conjunctiva and sclera, stabbing and then going nice and flat again. Staying flat allows me to tunnel the needle through the scleral tissue, 2mm, and then I dive down. You have to tunnel through the scleral tissue. Very, very important. And the only way to do that is to stay nice and flat. You can see here I'm moving the needle back and forth because I'm trying to puncture through the capsule material. I didn't eat the capsule completely here. So I'm puncturing through the capsule here, and then I'm grasping the leading haptic docking the haptic on the bevel of the needle, turning the needle to face the haptic and not the other way around. 2 pushes and then I'm in. Turning on infusion, I pull both needles out a little bit and then I pull the left side needle all the way out, pulling straight back towards me, grasping the haptic but limiting how much haptic comes out of the eye. Lifting the haptic a little bit and then cauterizing the tip. You can see a nice flat approach of that haptic. It's nice and flat to the sclera, which means I achieved a nice scleral shelf. Pulling the right side needle away from me, and as I pull away, I make sure I grasp the haptic, limiting how much haptic comes out. Drying the surface, and then cauterizing the tip. You can see both haptics are nice and flat to the sclera. Again, nice scleral shelf. This is not a flagpole sign, which means the optic is not sagging. By having a nice scleral shelf, this will simulate the appropriate lens position for an in-the-bag IOL placement. Reapproximate the conjunctiva. Do some more anterior vitrectomy. This is the surgical PI, going to create a small PI temporally. Again, you don't want to go too far out because if you go too far out, you'll eat the ciliary body. You want to perform the PI like you would for a laser PI. It needs to be visible. Placing the 10-0 nylon suture to close my main incision. Bury the knots. Hydrate my incisions. Removing the viscoelastic from the anterior chamber on cortex mode. Removing the trocar cannula. Turning on infusion. I can see the conjunctiva is ballooning, so I'm going to close the sclerotomy with a 10-0 nylon suture. And that'll be the end of the case. And so I have performed many cataract surgeries in situations where I have an anterior capsule tear. Again, it's not a whole lot, but in cases when that's happened, I've been able to avoid vitrectomy. I've been able to put a single piece acrylic lens in the bag without any trouble. And that is because the tear doesn't propagate posteriorly and the lens will solidify. The acrosoft material is nice and tacky. If you position the haptics perpendicular to the tear, it stays put, it won't rotate. And that should be essentially a non-complicated case. But because this patient threw up, and because I didn't suture the incision, which in retrospect I should have sutured the incision, I believe the incision was compromised. As a result, the increased pressure with retching must have blown open the incision. It caused the posterior capsule to split. It caused vitreous to come forward. It caused the lens to descend, and the vitreous came into the anterior chamber. And so you saw that I was able to cut the lens out, doing a Pac-Man technique, perform some vitrectomy using intracameral triamcinolone to help me, and then I performed my Yamane technique using the AR40 lens, again externalizing the leading haptic through a contralateral limbal incision using a 25 gauge needle passive docking technique, and then stabbing the conjunctiva and sclera and tunneling 2 millimeters, making sure I'm passing the needle through the scleral tissue using counterforce to ensure that my marks are correctly aligned. And by doing it that way, you saw how well centered I was. I put some sutures in her incision, so I will see how she looks after I take those sutures out. But this patient did very well with a well-centered lens. Again, a Yamane technique after anterior capsule tear. So I hope this was helpful to you, and I thank you for your attention.